Hello, and welcome to Informatically Speaking, the Greater Delaware Valley ANIA podcast designed to promote knowledge sharing in the field of nursing informatics, locally, nationally, and globally within our unique industry. At GDV ANIA, we are committed to providing opportunities for professional development with the goal of advancing nursing informatics practice. I'm your host, Constance McLaughlin. Welcome back to the GDV ANIA podcast, Informatically Speaking, a podcast for practicing informaticists and informatics enthusiasts alike. Today, we welcome Dr. David Wilcox, a doctorate prepared nurse, who also holds a master's in health administration and is a board-certified nurse informaticist. Dr. Wilcox has 28 years of healthcare experience, in which he worked as a bedside nurse, hospital administrator, and in healthcare information technology. Dr. Wilcox has been published in Health Management Technology, American Nurse Today, and AONL Voice for his work in patient throughput, healthcare mobility solutions, and for the use of technology in wellness and patient engagement. Dr. Wilcox is the author of the book, How to Avoid Being a Victim of the American Healthcare System, a Patient Handbook for Survival. Awesome, David. Welcome. Thanks for joining. Yeah.
Thanks for having me, Constance.
This is great. I'm excited to talk with you about this book. You have such a varied background in healthcare, and your journey, I'm sure, into healthcare information technology is unique, as is all of ours. But give us a glimpse into the book. What prompted you to write the book, and about how to navigate the American healthcare system?
Yeah, so it's all part of my personal journey. So when I was younger, in my teens, I had a special needs daughter. And I used to take my special needs daughter to various appointments, and I saw a lot of caring clinicians, but I also saw a healthcare system which was really broken. And I was working in manufacturing at the time. I got laid off from that job, and I decided I want to be a nurse. I want to go to work, and I want to be able to do something that impacts lives. So I started my journey there as a licensed practical nurse, or an LPN. And then I liked it so much, I went right into RN school at a community college. And all along the way, I was like, well, I'm impacting people's lives, like at the bedside and things like that. And then eventually I moved to North Carolina from New York State, and I was asked to run a hospital at night, and they told me I had to get my 4-year degree. Got done with that. They told me I had to get or they didn't tell me, but my buddy came in and said, hey, let's get our master's degree. And I said, okay. And so we did that. And then eventually I went on and got the doctorate degree, and a couple of certifications along the way. But all of that to say, when I finished that doctorate degree, I thought to myself, where do I take my knowledge base? Like, I didn't want my boss's job or my boss's boss's job or any of that stuff. I was comfortable where I was at. So where do I go with this knowledge? And I thought, you know what? I'm going to write a handbook for patients, because the patient perspective, I mean, they go into a hospital and they're scared to death, right? They're out of their element. They're, all of a sudden they got a gown with their backside exposed. You have to eat at certain times of the day. It's loud. There's people interrupting your sleep to get vital signs. So I thought, well, why don't I write a book that prepares the average person for how to navigate the complexities of the American healthcare system? Because the American healthcare system is very complex, and it's complex for a reason. There's people vying for your healthcare dollars that just don't want you to understand how to navigate it. And those are insurance companies and pharmaceutical companies. All those kind of entities have grown up around the healthcare system and are making mega profits. So I wrote the book to be able to help people navigate it. And it's funny because some people will tell me they read the book in its entirety, Other people will tell me, God, I was having a terrible time with United Healthcare, as an example, they were denying all kinds of stuff. And then I read your chapter on insurance and I knew exactly how to go back at them. And that was the purpose of the book. Patients are the key to what each and every one of us do every day, whether you know it or not. When you wake up, you're going to make some changes in an IT system, or you're going to make some changes if you're a bedside person, that are going to affect patients' lives. So that was the purpose of the book.
And I love the fact that it's down to earth, the like a self-help kind of book. And like you said and alluded to, folks might read it all the way through, but then they use it for reference, right? So they're going back and they're looking at those chapters on insurance or I can't remember them now. I went through it before, but like Medicare or
Pharmaceuticals.
pharmaceuticals. Yes,
Yeah.
that's a huge one. And knowing just how to navigate in general is really priceless. So it's an awesome piece of work. So what would you say though, like through your research, let's talk about all of us really as the patients, right? So through your research and writing the book, what would you say is really the main entry for patients in healthcare? Like, how are they accessing it?
Sure. So that's dependent on their skill level, right? But for most people, they need to see a doctor. They call in for an appointment. If you have something as slick as a patient portal that actually is conducive to, the patient understanding it, you can get right in there and you can just schedule an appointment with your provider. You know, Other various points of entry, of course, are if you're in an emergent situation, you're coming through the emergency department, which is always usually not a pleasant experience. And then, there's just various places where they can come in. I think that us as informaticists, as clinical informaticists, we have a duty to make the patient portal as easy and as consumer friendly as possible. And what I find fascinating in healthcare is that, and you guys have seen this, there's people at the top that'll make decisions and they'll roll them downhill. And usually those decisions don't get adopted. But if you take end users, so you take people in your community, say, hey, we're working on this patient portal. We want to get your input into it. What do you like about it? What don't you like about it? And they'll give you good points that you can hone in on and make some changes and get it ready for the actual customers. I think that's very important because, a lot of patients feel like they don't have a voice. Like I'm going to do whatever the guy or lady in the white coat tell me to do, right? I'm going to do whatever the nurse tells me to do. But they don't understand that they really are owners of their health care. So if they're eating, I'll just say Chick-fil-A every day because I'm in the South, and all of a sudden they're getting stents placed, in their coronary arteries. They're not really owning their health because they leave after they get the stent placed and they go right to Chick-fil-A. Nobody's instructing them that, maybe your diet is a cause of why you're having stents placed or having, heart attacks. They don't know that stuff. So people have to own their own health. It's just like if you're going to go out and buy a car, you're going to sit down and do some research, right? You're not going to just walk in and write a check or, take out a loan. You're going to do some research. And people just don't do that in healthcare. They just think, well, these guys are professionals and they don't realize what the insurance company's demands are on the doctor or the nurse to see so many patients. And people make mistakes. I mean, medical errors are still the third leading cause of death. And so, the patients have to be educated and they have to own their health care.
It's true. And I guess, when we're healthy, we think we're healthy. We don't think about it, right? So we're not thinking about the things that we are doing to ourselves willingly,
Right.
and then what the implications of that are. But when we talk about the portal and the digital front door, I think you're right. Everybody has to be educated and continuously educating ourselves because healthcare changes, because insurance changes, the policy changes, and you sometimes wonder if they do it on purpose. Um, But as far as the front door goes, things like an expansion of the conversation. You were just talking about the portal, and yes, they are becoming more robust. But now we're also seeing the billboards that have wait times for the local places. As you're driving along, you can see that, or even on the portals or on hospital websites, you'll see what's the average wait time in your area? So different hospitals that participate maybe in the same platform that you might be on at your hospital. So it's really interesting to see how this is all playing out and evolving.
Yeah, I'll share a personal story with you about that. So, my wife had fallen out of bed and fractured her collarbone, and so I took her to an urgent care here locally. I'm in Charlotte, North Carolina, and when I went in, they said, "Do you have an appointment?" And I'm like, "Well, no, nobody knew she was going to fall out of bed and break her collarbone." It's like, should I have called ahead like the day before it happened? I don't know, but anyway. So they said, "You have an appointment?" I said, "No." And they said, "Well, it's going to be at least a 6 hour wait." And I said, "Okay, so we're going to go back to the house because we were only about 10 minutes away. And you can just call us." And they're like, "Oh, no, you have to stay on the grounds." And I'm like, "What? You want us to stay here for 6 hours?" And they were like, "Yeah." And I said, "Do you have any of your other urgent cares that have less wait time?" And they looked in the system. They said, "No, they're all about the same." Well, I knew that there was an urgent care down the road for me that was not affiliated with the hospital and the healthcare system that I was trying to access. So I said, nuts to this. I said, let's just go down there because I didn't see that many cars in there. So we went down there and we got seen. They couldn't do the X-ray down there. We had to, drive a bit to get the X-ray done, but we were able to get done and out of there in like an hour and 45 minutes. Had I not been a healthcare person, I might not have known, like, I have options here, right? I don't have to wait for 6 hours. The average layperson who's got a broken collarbone, they're going to wait there for 6 hours because they didn't call ahead and schedule an appointment. That's so bizarre. But anyway, but anyway, to my point is I was knowledgeable, I was educated, and I didn't have to sit there and wait 6 hours.
Agreed. That just makes me laugh and remember about the years and years ago when I worked in the OR. There used to be a doctor that would call during the week and say, "I'm going to have an emergency on Friday." So you need to schedule this for me. It was very strange. Anyway, I digress.
Hey,
But
can you
what
do that? Hey, what can you do that with lottery tickets? Like, I want to know the winning numbers the day
that would be
before.
awesome. I would love that. I could use that.
Right.
Oh my gosh. So thinking about the just this conversation about patients and knowing what they can do, what that they even have options. But that's just for anybody to guess at this point because we know that many people don't really educate themselves on the healthcare system or what they should be doing. They're just living their lives, right? But as informaticists, how are we and how can we help in that journey of improving patient care? I mean, we work on things like the portal and the hospital system as a whole is huge, but community is really springing up more so now. I think a lot of healthcare institutions are branching out even more so than they were. I think their strategies are more towards the community at this point, but because it really should be geared towards wellness versus treating the sick in the hospital. So, talk a little bit about your research and your informatics experience and how we're making things better.
Yep. So let me preface it by saying that our healthcare system is not set up for wellness. It's fee for service. And if you don't access the healthcare system, they don't make money, which we saw during the pandemic.
Yeah, and what happened to that? They
Yeah,
talked about that in the 90s. Oh, we're going to change it and it's not going to be fee for service anymore. Any
right.
insight into that?
Yeah.
What
So,
happened?
so what happened was it's a model in which they can collect the maximum return. So, you know, as far as healthcare entities like insurance companies and pharmaceutical companies, they lobby Washington all the time. These guys that we're electing, they're in the pockets of the insurance companies and the pharmaceutical companies. So they're not willing to make many changes, right? One of the most promising things we have out of this is something called value-based care, which is basically a capitated amount. So, I get a certain amount to take care of Constance. And then if I can keep her healthy, then I get to keep the profit. But if she goes to the ER, I got to eat it, right? So that's a true wellness model. That's the kind of thing that, we need to see flipped. So every American is kind of like on that system, but we won't because, as I said before, the politicians aren't incentivized to do that.
It's a
But
shame.
going back to your informaticist question. So what we do, the one thing that I think, if I had to sum it up in one point, the way to help our clinical staff and the way to understand what the patients need is to actually connect with the end users. Back in my day when I was doing patient throughput, we had bed meetings and stuff like that, but I walked onto every unit and I talked with the PACU to say, hey, you're going to have a crappy day because things are going to back up. I went to the ED. And so my boss said to me at one point, she said, everybody loves you. What are you doing? And I said, I'm just walking out there and connecting with them. And once you hear their perspective, like, you go and get what everybody loves is you go and get the crabby physician, right? And the guy who's like, this sucks, and he's like, you guys did this to me and that kind of stuff.
Mhm.
But if you ask him what sucks, like, let me help you make it suck less, um, tell me where you're struggling. And you guys have got tools in the back end. You can see where people are struggling. So if you do that and you can help them, I mean, then they start to value the relationship. But if we're sitting in an office all day, just writing code or whatever the heck we're doing, we don't get that perspective. So I think it's really important. And some of the most successful organizations I've seen with informaticists actually go out and spend time with the clinicians.
I love that you just said that because rounding and building those relationships, I think is the most important thing in our work as informaticists and having conversations about not only what they're using and how they're using it, but then the data that's presented to them, or maybe they're not even looking at it or realizing that they can look at it in the form of dashboards to help them make decisions about throughput, right? So there's so much that they can be looking at. Rounding is something that has always been near and dear to my heart. I think it should be 30-40% of your workday, to be out there to observe, right? So it's not, and I always say this because someone had said this to me a long time ago, and I use it and I shamelessly use it, howdy rounds, because it makes me laugh, but it's true. When informaticists just walk on the floor and say, "Oh, hey, we have this, upgrades coming, and here's a flyer. See you later." You're doing yourself and them a huge injustice, by, first of all, not really connecting anything
Right.
about the technology, but then also just running away from the situation. And you might not feel that that's what it is, but if you're there to not only to connect and have that relationship, but you should be watching everything that's happening around you while you're having that conversation, right? And my most valuable times while rounding, we're seeing things that I just thought were totally bizarre that they were doing with the technology, right? Scanners and all kinds of stuff. And you're thinking, how the heck, what, but you're the only one seeing it because they're just living their lives and trying to take care of their patients. That's the part that you need to be focused on, right? I mean, you
Yep.
can teach them how to use the system, but if you're not teaching them how it's connecting with their practice, wow, that's a huge miss.
Yep, definitely. And like I said, a lot of the organizations that I've been with a lot of organizations, is the people who round when you walk out there and they're like, "Hey, I know you." I'm thinking of an example of a guy that I know down in Lakeland at Lakeland Regional, Malcolm. Doctors love him, but he's out there and they're like, "Malcolm, this doesn't work." And he's like, "Well, let me take a look at it." And he works alongside of them. Those kind of people that do that are usually the most successful. Um, it's just, I've actually rounded at hospitals and I've had to introduce the informatics people to the clinicians because they've never met them. I
Me
mean, that's
too.
that's crazy. Like that should never happen.
That is
Never.
so true. That is so true. So I wanted to touch on what you said about the physician who says, "Get away from me. You did this to me." Just the resistance and the anger. And of course, I think we've seen that it was probably worse in 2001, 2002, when we were
Yeah.
watching physicians call from the stairway, call the unit and tell the nurse to put the orders in. I mean, I think we're past that now, but we still have people who go from place to place, right? They go from hospital to hospital, or they work in different practices, or even urgent cares using different systems. And they're, of course, all their instances are different depending on where they are, and they get frustrated because they're not seeing the same thing in the same place. It's not McDonald's.
Right.
Everybody has different systems. So how that resistance piece is so difficult, and I think a lot of people struggle with that. How can we help not only with that, but then the perception of the technology for the colleagues that we work with on the front lines, but then also for the patients too? Kind of feel like it ties back into that, bringing them into the fold.
Yep. So a lot of people don't like confrontation, because we elevate doctors in this country, whereas in Europe they elevate professors. But it is our culture and it's the way it is. So when a doctor gets mad and starts yelling, sometimes people take that personally, but it's not personal. What they're actually trying to say, if you just remove all the emotion from it, they're trying to say, "I am frustrated. I don't understand this, and I'm taking it out on you," right? So if you can get to the key core thing that's frustrating them and work with them on it, you usually leave and they're thanking you for it. The thing is that you have to set your feelings and emotions aside and just say, "Okay, so this guy's pissed. What is he pissed about? And how can I help make it better for him?" And you may not be able to. You might say, "Oh yeah, I see that. Okay, let me get a screenshot of that. Let me take that back and let's get working on that. I can't fix it today, but I'm going to keep in contact with you. What's the best way to contact you?" Just that personal interaction right there. I mean, the guy feels like he's heard. He feels like there's somebody doing something behind the scenes. And then most importantly, follow up with them, even if it's like, "We can't fix that. I'm sorry," but follow up with them because then they're more apt to come to you. Many clinicians will like maybe put a ticket in or something, and then they see no action on it. And then they're like, "You know what? I'm just going to live with it. This it's terrible. I'm just going to do it."
The
Um,
black hole.
yeah, and that's where you don't want them to be, right?
Right.
That's where you don't want them to be. So, you know, get out there, get your hands dirty, right?
Agree, agree. And I guess I'm wondering from from a patient perspective, or even my perspective. I know that I've never seen in my area anywhere where the hospital or whatever organization, healthcare organization nearby, was actually inviting patients to come and say, "What do you think?" Right? There may be some kind of a forum to talk about the community and healthcare, but I don't know that I've ever seen that. Have you seen where healthcare companies are actually asking patients to come and look at the technology that they're interacting with? Because just jumping off of the last conversation about your relationships, you don't necessarily have the relationship as an informaticist. You don't have relationship with the community and those who may be coming in contact with your organization, but they are using the technology that you're supporting and putting it out there. So I guess just kind of stretching it a bit and connecting
Mhm.
it in a way that have you seen that in the community?
Over my 16 years in healthcare informatics, I've seen it twice. And the reason,
Wow.
and both places had a very dynamic leader that said, we can build this stuff all day, but I need to get the community's perspective. And so they did. They brought in end user groups and showed them. One was around the patient portal. I can't remember what the second one was around, but only two places. I mean, you know, that's that should be an everyday occurrence, in my opinion. If you're designing like a patient portal or something, you can design all day. But what do they find most value added? It's important to
Agreed.
figure that out.
It is. It is. So let's take a jump here to a little bit of a different topic. And everybody wants to know about AI. Everybody is talking about it. I think there's pockets of people still trying to figure out what the context of it is. I mean, we know the definitions of AI and machine learning, and all of that, but to me, and I think I've said this on other podcasts, we're digitized, but we've not transformed fully, of course. I think it's the AI, the promise of AI that we're um, looking toward for that transformation, right?
Mhm.
Because over 20 years ago, when we started this whole thing and we started implementing, and we were still trying to figure out our jobs as informaticists with this whole EHR, um, we started asking people to type things, and we still are. We're we've asked our nurses and physicians to become typists. I think that was your thought the other day. And with AI and the promise of it, we're seeing the trickling of what it can do,
Yeah,
but we can't predict really fully what it's going to be. But we do see a glimmer of hope just through some of those things like administrative tasks being taken care of, or even, through ambient listening platforms where, it's suggesting things. And don't forget, you have this lab result over here, and that might, so the system is not taking over, but it's making suggestions and some recommendations during those wellness visits and things like that. So, I mean, I guess tying it back to the book, um, let's maybe talk a little bit about how AI is helping our communities in this American healthcare system.
sure. I think we have to kind of understand the history of why AI is so important in healthcare. And there's schools of thought. Some people want to embrace AI right out of the gate, and some people are very hesitant to embrace AI. But when we first started to digitize the electronic medical record uh, many years ago, we created such a burden on the clinicians. Like you said, the doctor's like, hey, I'm not a typist. I don't even, they're two fingers like this, pecking away at the board. Um, they're like, this is really, really costing me a lot of time. And it was, I mean, we just burdened them like crazy because we wanted accurate records because we needed that into a digital form. The government incentivized, the hospitals, you get a certain amount of money for meaningful use and all that. So as clinicians, we just had to suffer through. Now, if you look at the promise of AI and what AI is doing in healthcare, so as you alluded to, ambient listening. So you can actually take a device, a phone, whatever it is, in with a patient and say, hey, I'm going to record the conversation. Are you cool with that? And they say yes. And it'll pull out all the pertinent information. It'll write the note for the doc. It'll code it, right? Very efficient. Doc just has to review it and then sign off on it. Docs who are using that say this is a game changer, which it really is. I can go to my kid's baseball game. What does it look like for nursing? So for nursing, it's kind of cool. I've been involved in this in the early stages of it. So with nursing can go in to do head-to-toe assessment, turn on the AI by saying, "Hey Google" or whatever, "Hey Epic," "Hey Oracle," "Hey Cerner." They can turn it on, and then they can say, "Yeah, I'm doing my head-to-toe," They'll be listening to the patient's lungs and they'll say, I got crackles in the left lower lobe. And the AI may generate a comment to say, did you check for peripheral edema of the lower extremities? Which gives the new nurse a 20-year perspective, right? And the nurse says, oh, 3+ pitting. The system's recording it. And when they're done, all they have to do is review the assessment and sign it. So why is that so important? Because today, when a nurse goes into a room and does an assessment, there's very little words spoken between the nurse and the patient. And and then they go out and they're like, I just got to get out of this room because I got to go document this before I forget it, or I've got 6 other patients to see.
Right.
So they get out of the room and document it. Well, with the AI and it being documented for them and them speaking out loud while they're doing the assessment, that creates an opportunity for patient interaction, patient or family interaction. And so they can say, the person in the bed can say, "Is that why I take that water pill?" And the nurse says, "Yeah, and you're probably going to take 2 of them today. I've got to call the doctor." But it creates the opportunity for them to actually own their healthcare, as we talked about earlier, or be a part of their healthcare, as opposed to just going in there with a cold stethoscope, listening, running out so you can document it. It's going to be a game changer. Will there be some hiccups? Yeah, of course. You got to train it for specialties. Like if you're a cardiologist, you don't want the same setup as somebody who's a GI doc, right? You got to train it for specialties. But this is huge. Like we did all this burden stuff, early on to clinicians because we had to. But this is the cool stuff. This is where the benefit is, and I'm excited to see it roll out. I'm excited to see the majority of the people who get it. I love it. Nursing hasn't really been rolled out to nursing yet, but we as nursing leaders have to teach nurses to do things differently, which might mean speak the assessment and interact with the patient's families because they're not documenting. But I think it holds real promise for the clinicians, and I think it holds real promise for us as informaticists, right? Because now we can go out on the unit instead of the doctor going, "This sucks. You did this to me." It's like, "Hey, this is great. You guys, I can't believe you developed this. Like, I'm going home and I get a lunch break now, and that's really important, and that's what we're going to see more of as it continues to roll out.
Agreed. And I have to think about, so years ago, I did a lot of work on burnout and wrote about it. And just the cognitive load that our colleagues have now with the typing and the looking for lab results, and they might not have to remember all of the lists of things that they have to do for everything, for every patient that they have, but the cognitive load is still pretty heavy. I'm seeing AI as helping to alleviate that, hopefully, but it'll still bring its own challenges, I'm sure. But the moral of the story really is for all of us to be aware of the things that are out there so that we can start to assimilate how we're going to change our practice to implement this, design this, implement it, and support it as well, keeping in mind that burnout factor, that cognitive load factor, because it's important for us to stay focused on that.
Yep, definitely. And the AI, that technology we're talking about has been shown to significantly reduce burnout. So it's just a faster, easier process. And most importantly, it's conducive to the clinician's workflow. The EMR is not conducive to the clinician's workflow. Um, the goal being that with the use of AI and technology, a clinician may never have to put their hands on the keyboard again. I know that sounds crazy, but that's the end game. That's the end goal with it.
I would love that. I've been hearing whispers about the wearables that you can talk into. But just to go back to as an inpatient nurse, a former inpatient nurse, just the thought of having the opportunity to teach the patient as you're in the room at the same time that you're doing assessments, preparing meds, all of those kinds of things. We would do that anyway, but if we're speaking out loud about the things that we're thinking, their assessment, and so that the ambient listening program is picking it up. That's the kind of thing that it's a culture change, right? It's a total culture shift for a nurse to not lay hands on a keyboard, for a nurse to be speaking out loud about what they're doing in the room at that time. And then I mean, I can't imagine not having something to write with or something to type with, to just have this thing in the cloud listening to me, and then still getting everything done. Because believe it or not, we still have a lot of folks out there who are documenting, uh, over documenting, like it's 2004. They're still documenting everything, afraid that of the litigation, that if they didn't document it, it doesn't happen. I mean, there was like 1,000 different thoughts in that in that whole
Yep.
rant. But oh my gosh, this is the kind of stuff I think about when I think about AI.
Yeah. It's interesting because, after meaningful use, there was a big push on optimization and some of the stuff that you said about talking with the patient. So, the pandemic, um, taught us that the use of virtual nurses, if done correctly, is pretty cool, right? So that was our first step into like, let's remove the administrative burden from the nurse and let's give it to somebody who's at a computer who can interact with the patient, uh, uh, and can get more time with the patient than the nurse who's running around with six patients. So what we saw with that was that, especially in discharge. So, normally a discharge would be, you run in as a nurse and you bring in all this paperwork and you're like, hey, here's your new CHF diagnosis. This is what you're going to be taking, blah, blah, blah. And the patient's like, God, I've been here for like 3 days. I am so tired. Just give me the thing to sign and I'm out. Right. And then they go back home and they don't understand any of it. And then they fry you on an HCAP, survey. So,
Yeah.
so what we saw with virtual nurses is the nurse says, hey, you got CHF diagnosis. Let me tell you about what the drugs you're going to be on. Let me tell you about what you can expect. Let me tell you about how healthy it is for you to change your diet, that kind of stuff. They have the time to spend with the patient. And what we've seen is that patients go out the door much more satisfied using a virtual nurse than they do the nurse who's running around with their hair on fire, right? Doing everything that they have to do. Um, those are valuable learnings for us in healthcare to understand that that works, right? If you can have somebody whose sole job it is to like get the patient through their experience, teach them so that they don't come back to the ER in 30 days and you have to eat that, right? Um, that's very valuable. And using the AI where we decrease the burden, the burnout of clinicians so that they have time to do stuff like that is going to be very, very important. I think that 5 years from now, Constance, when you go into a hospital, it's going to be a total game changer. You're not going to see a lot of wows and things like that. You're going to see some scanners for medications, but I think you're going to see more of the AI in the hospital. And some of the early adopters who are doing, trying to do this now, they're having great results. So it's time to shift the way we deliver care, and it's time to shift it and make it less burdensome for the clinicians. And all of us as nursing informaticists are going to play a part in that, whether we're hesitant or whether we embrace the technology and we pull our clinicians over the line. We're very important to this process. Um, and so, yeah, the work that everybody does here, very, very important to getting good outcomes and a good clinical experience and a good patient experience.
Agreed. Agreed. And then we can't talk about all of this implementation and support without talking a little bit about metrics, and measuring those things. So I think sometimes as informaticians, we're so caught up in what's the next thing? Okay, next project, that we are not stopping to not only help our clinicians, at the bedside or in the offices, but we're not looking at the impact that we're making. And that's something that probably deserves its own hour on the podcast. But just to to just bring it back, bring it down and reflect, for all of us to just sit right now and reflect about how often we actually look at our impact on something that went in 6 months ago, a year ago. Like you said, we're implementing all of this, but then the patient is just tired, they want to get out, and then they fry us on HCAP. So what's the correlation between the ambient listening that you just implemented, or the virtual nurses that were just implemented, and taking that data and taking a look at it and taking a look at readmissions, or
Yeah,
and just kind of going through that just to start diving in and looking at what you're worth.
yeah, exactly. So what I've seen a lot of around the ambient listening is that they clock the amount of time the doctor was doing notes before, um, and and then they compare it to what they're doing with the ambient listening, and there's always, it always decreases. I think that as informaticists, so I'm also a Lean Six Sigma black belt, and so process improvement and metrics is my thing. But I think for anybody who's listening to this, if you want to get ahead, um, clock your metrics before you implement something and clock it, 90 days after, because it takes 30 days for a good solid change. 90 days after, and show it to your boss and say, "Hey, here's the impact we made." Um, People love metrics. And if you can't prove that what you're doing is value added to clinicians or patients or anybody, then you may have improved something, but it doesn't get you any further because people don't understand the work you put into it. So always clock your metrics. There's a way to do it. A lot of these EMRs have built-in reporting tools that you can actually see. Some of them even allow you to do sprints, which is basically, you're going to say, I'm going to target every doctor who's below 80% on CPOE, and then I'm going to go after them, and then I'm going to raise it up. You can do it. The tools are there to do it. We just have to take the time to understand that in our careers, if we want to get further, if we want to get noticed for stuff that we're doing, then we have to have the metrics. We have to have the baseline metrics, and we have to have the outcome metrics.
Agreed. Well, I could keep talking all day, David. It's been great to reconnect with you and talk with you about how informaticists are connected into all of this. I love talking about your book as well, How to Avoid Being a Victim of the American Healthcare System, A Patient's Handbook for Survival. You can pick it up on Amazon, and I believe Dr. David has a website as well. You can go
Yep.
there. Yeah. What's the name of your website?
So the best one to use is drdavidhelps.com, drdavidhelps.com. I also, for patients, if they sign up for my newsletter, I give them a free healthcare resource guide, which is basically one-click access to things like Mark Cuban's online pharmacy, a price transparency tool called Turquoise, and even organizations that will take a patient's complex medical bill and say, if I can save you money, I keep 30% of it, and they'll go through it and they'll actually drive down the cost 90% of the time. Um, all kinds of access for patients. And, if you have older family members that don't quite know about the healthcare system and they're avid readers, my book is definitely something that, you can gift them. I've gotten, if you go up to Amazon, just look at the reviews, it speaks for itself. But drdavidhelps.com, that free healthcare resource guide, yeah, there's a link to the book up there. There's a link to my major website, drdavidwilcox.com, which I have to update a little bit, but because life is life, right, Constance?
That's
You're,
right.
you're doing stuff, and it's like, oh, I'll get to the website when I get to it.
That's right. Well, we do appreciate that, and that's advice for everybody. Get out there, take a look at it. We're all patients at one time, and if we're not now, we will be in the future at some point. So I'm sure we could all benefit from that. So thanks for joining us today, David.
Yep. And just remember, it's not a matter of if you need healthcare, it's a matter of when you're going to need healthcare. So everybody's going to go through it at some point.
That's exactly right. That's
Yep.
exactly right.
Well, thanks for having me, Constance. I've really enjoyed our conversation, and I hope I've helped some people, and maybe even I've learned a little bit myself. Hopefully, everybody else does too, right?
I'm sure they will, or they have. Absolutely. Thanks, David.
Okay, thanks, Constance.
Thank you for joining us today. We hope you'll join us again for another session of Informatically Speaking.
This has been a production of the Greater Delaware Valley chapter of the American Nursing Informatics Association. For more information about the GDV ANIA chapter, visit us at community.ania.org/Greater Delaware Valley/home.